the idea for this topic.
Yeah.
Because there's a guy at the gym. I'm like, we were all hesitant to start, and he was like, I just started meds. I don't really want to do it. And I was like, oh, you just tell he's not the right dosage. He was so stiff.
Yeah.
And I was like, I'm telling you, I was the same way, But I was like, once you get into it, and you start to see the difference and what the medications do. You were like, what the hell was I waiting for?
Yeah.
Yeah.
Well, and so
that's a big thing that's out there.
Yeah. But so that's what I want to focus on for this episode is, what people waiting versus not waiting and whose decision and things like that. So, yeah. Welcome to The Secret Life of Parkinson's, a podcast created by people living with Parkinson's to help break the stigma of a disease no one likes to talk about. Now, here are your hosts, Jessica Krauser and Brian Baker. But so with that, like, again, Brian had this idea of doing this topic of why people with Parkinson's are skeptical on starting meds. And from my standpoint, I see it that same way as well. Like, people that I've come across, and actually my young onset women's group, like there's a lot. And a lot of times it's because people just don't like medication in general.
I was going to say, I don't even know if it's necessarily a Parkinson thing. I think people in general, you don't want to be on a med. Like,
right.
Why? Right.
But the one thing that I kept going back to is, like, at least for young onset, I know you guys, I know movement disorder specialists, at least from the ones that I've heard from my friends, they're always told, like, you don't have to start carbidopa-levodopa first.
Right.
You can go to a dopamine agonist and things like that. And then I feel like it scares people away from carbidopa-levodopa in a way that they shouldn't be afraid of it.
Right.
Like,
but plus, the other thing I was thinking about this is also at that point in time that you start taking medication, you're starting to accept the diagnosis a little more. You're like, oh, this is real. It's not.
Yeah.
Yeah, and I think it's both things. I mean, the fact that carbidopa-levodopa is to this day the gold standard treatment for Parkinson's. The oldest and to this day still the best medication for Parkinson's disease. So that's true. And there are lots of other meds out there that have their role and what they do maybe a little bit better than what levodopa does.
Yeah.
But they also have their own slew of side effects that potentially certain older populations or whatnot may be more sensitive to. So you have this algorithm you kind of play with to figure out what would be the best thing. The biggest thing I tell my patients, I'm personally, firm believer in less is more. If you don't need it, I'm not going to give it to you, right? And also, second, like, I am seeing this patient, in a 20, 30-minute window. Them and their families, they're living with this every day, right? So I'm really depending on what is your day-to-day like? What are you going to tell me? And if you tell me, hey, doc, I could get through my day just fine, doing everything, I'm doing everything I want to do. Great. I'm going to circle back. Can you do it easier? Can you be faster? Can you be less slow, less stiff, more efficient? And could a little bit of more med help you do that? Or a little bit of med help you do that? And if the answer is yes, then fine, let's open the conversation, let's talk about it. If not, if you're like, no, I'm fine, then great. I don't need to put you on medication just because you have Parkinson's disease.
And that's the part that's like, sorry, I can't like breathe in. That, at least for me, is like hard to distinguish when I get asked, like, are you okay with where you are? And it's like, I almost forget what it feels like to be normal.
Yeah.
I really do. So I'm like, I'm fine. Could I be better? I'm sure as hell I can be.
I mean, well, we all can be.
Yeah.
Right?
But, like, for me, like, the stiffness, that's where, like, the rigidity and stiffness got to the point where, like, I was literally sleeping with a ball in my hand just to keep my fingers spread
apart.
Right. And,
so,
I wake up in the morning and try and stretch, and my shoulders would...
And that is a caveat, and that's the reason it is important to also have that conversation with caregivers too, because sometimes patients, maybe they're still in that denial phase. I mean, they're I'm fine, but then there's significant other, like, no, they're so slow, and they can't keep up, like, or they're falling without telling their provider that they're falling, right? Or their caregiver may not even know that they fell without knowing about it. That's a different scenario. Then we're like, listen, we need to get ahead of this, because that's the last thing we want is for you to fall and potentially hurt yourself.
It's like, why don't people think of it of like, because it can be severe, like with falling and you're really hurting yourself, but you're withholding medication, and one, you could just have the rigidity or the tremors, but there are more severe things, like I said, that can happen. Same thing with, like, I always go back to other disease groups. So whether it's heart disease or diabetes, you wouldn't not take your medication because that's really life-threatening. Mm-hmm. Why do we think of this differently?
Because it's the brain.
Not that, but isn't there the theory out there that eventually if you start using Carboleva, that it'll quit working for you?
Yeah, but we debunked that.
Yeah, debunked that, but it's still out there. There are so many people that still believe that. They to this day they'll say, "Well, I don't want to start that because that means I only have 5 years." Yeah. No.
Carbidopa levodopa doesn't have a what's it called? Like
expiration date.
There's no expiration. We get
right, and that's exactly it. Right, the disease progresses, and you have to adjust the medication in that way. So it's important. And even when patients are hesitant, they finally agree to go ahead and start medication. They come back and see me, and then they'll be like, "Well, I don't think the medications really did anything for me." Well, that's my role then, to see objectively, has that done anything for you? Because that's the reason why we examine you before. We do scales of testing to see where you are, and then I show them that, okay, this is where you were, and now this is where you are. Mm-hmm. And so from that sense, look, there's an improvement. Now they're bought in. Now that, okay, this is doing something.
So that's actually one of the question that I asked the podcast group and those of people who answered, I just said, for those who waited to take medication to treat Parkinson's but are now on medication, whether it's carbidopa, levodopa, or dopamine agonist, how do you feel? 58% said I started medication and found it beneficial. So that just goes to our point of, like, people that aren't on it and they are visibly and physically, like, not good.
Right.
It's there is benefit to it. 19% said I took medication but didn't experience significant changes. So you're saying, like, with those situations, you would just potentially modify them.
Modify them, or kind of go back to, well, what is it that you were looking for?
Yeah.
Right? So remember, because there's a lot of patients that say, well, I still shake. So that means the medicine didn't do anything for me. Mm-hmm. Well, we know that the medicine is there to improve slowness and stiffness. Mm-hmm. Whatever tremor control we get, great, we take, right? But it's there to make your mobility easier. That's what dopamine is doing. And it's there to make sure you move better, easier. Mm-hmm. And so sometimes patients may not, they'll be like, well, if my hand's still shaking, the med's not working, which is not necessarily true.
Okay.
Right? And I'm not someone that's going to medicate a tremor.
Yeah.
Because that's when we're going to get issues in terms of side effects. And then as soon as a patient starts experiencing a side effect, now you've lost.
Yeah.
So if you go in too heavy, too quick, and then now they're like, nope, I tried that. This is what happened. Not doing that again.
Well, so 6% said I tried medication and experienced negative side effects, and 8% said I wish I hadn't started medication. I've discontinued it. Right. But it means trial and error.
Exactly. And it could be that medicine wasn't the right med for you.
Right.
And so we
what
go
medications did they try? That's the other thing, too, is...
Well, I put in there specifically CL or dopamine agonist. No, but I mean, so I actually was speaking at a support group today, and one of the individuals said, he just gets nauseous on levodopa, so he's like, I can't take it. Mm-hmm. So he's like, what else do we have, like, as in our toolkit? Right. And so I was like, one, I'm not a doctor. Right. I was like, but you can, talk to your doctor about, like, do you go to get DBS? Do you look at a dopamine agonist? Right. Or,
there are modifications around it. Mm-hmm. There are other ways to alleviate some of the nausea, whatever it may be. But it is important. Yeah, and these medications, they are. And that's part of the I think, hesitancy for people going on it compared to a blood pressure med or insulin or diabetes medication is these meds are, in a way, manipulating the chemistry of the chemicals in your brain.
Yeah.
Which could be scary. Right. Mm-hmm. And so I think that's where sort of this hesitancy still lies in terms of people like, well, what are you going to be doing in there? Right. What are these drugs actually doing to my brain? Mm-hmm. And so having that sort of, and that's fair and that's appropriate. But so trying to figure out ways that we could compound, okay, if this is happening, we could get around that, but have that honest discussion with your doctor. And, there are times where I get patients I see them 3 months later, I'm like, okay, well, last time I recommended we try this, this, and this. Oh yeah, I did that, but then this happened, so I stopped. But I don't know about it until 3 months later. Whereas if I knew about it as it was happening, we could have talked through to figure out what it was. So being an honest conversation and realistic conversation.
I would never stop myself
with your
on
doctor.
something without talking.
Yeah.
Well, and even
you do.
Well, even when I was doing, even when I was started out and taking, he had me. The doctor had me like on a half a pill or one pill, and I was like, I'm not cutting this stupid thing in half. I'm just gonna take the whole thing, And then went back in, and that's when he explained to me, he's like, this is a half pill can really make things a big difference. And you go, I wish, and I was like, oh well, having Parkinson's, trying to cut those pills in half, I was like, I'm just gonna take the whole thing or whatever it is. And so then of course I'm not medicating myself to the way the doctor prescribes, so the results are going to be different,
But have that realistic conversation, because that patient has said to me, if I'd say, okay, we're going to add on a half a dose, and then they'll come back like, I tried cutting that in half, and it doesn't work that well, or the other half of it crumples apart. Now I've lost med. And so then, okay, this cutting pills is not the thing for you. So let me see what I could do to get around that.
Right.
Well, do you recommend that there's that pill that you can break apart?
I haven't, frankly honest with you, I haven't prescribed it to anybody.
What's it?
Starts with a D. I forget what the name of it. But I haven't, just because it's chunky pill. That's big.
So if you have to take the whole thing,
if you have to take the whole thing, I would not be able to. It's pretty big. And then so trying to cut that into 4s. Yeah. Again, you're still having to. It's still dexterity things, tiny, small. Like
that's true.
It's not. I don't see how that could really truly make a PD patient's quality of life better. Mm-hmm. For me to go through the hassle of getting insurance approval, blah blah blah, getting it. So I had not prescribed it or attempted to prescribe it.
There was another thing that I wanted to say about with as it relates to when you're diagnosed and talking about prescriptions. I didn't know going into, I didn't know anything, but like when I went to my next appointment and then the subsequent follow-ups after that, I was going like every 3 to 4 months in the beginning because Dr. Malone was trying to figure out the right dosage and stuff. What I didn't realize, and I don't know if you experience this or if you see these with patients, but I feel like there's probably been one time in 5 years that I didn't increase my meds or change my meds at an appointment. Is that normal?
Yeah.
Really?
I
no? Yeah?
I feel like obviously every patient's different.
Yeah. And but maybe I'm being drastic saying one.
Yeah, I would hope to keep people on a steady dose for as long as possible. Mm-hmm. And I feel like I have more appointments where we're looking at potentially not making any changes versus, okay, well now let's add on this, add on this.
I think early on I was the same way with Dr. Hinkle because we're trying to get the right
concoction.
Combination, concoction, whatever. Mm-hmm. We're adding amantine, we're adding Mirapex. Okay, we're taking away Mirapex. Okay, we're gonna add half of the that type of stuff.
And maybe it's because like we are so vocal. Like I tell her everything.
And it could be that, okay, if you're telling me that, hey, I'm struggling with this and this, my job is to make you feel better.
Yeah.
Right?
Yeah.
And so if you're saying that, then okay, I'm going to say, well, then I would recommend this, and this. Mm-hmm. But if that's not the case, and it does depend on sort of patient population, patient education. I have a bigger practice in Southern Ohio that, it may be, they may have better understanding or not better understanding of what's going on. Education levels are different, socioeconomic status are different. And so they're just going to be like, I'm fine.
Yeah.
Okay. Fine. I'm not going to go in there and give you more meds just because I feel like because you have Parkinson's.
So one of the other questions that I asked the viewers is when diagnosed, did your physician give you the option to start medication, or did they just prescribe it? So, and I ask that because I hear a lot of people, some say, like, they told me, take carbidopa, levodopa, and I'll see you later. Right. Or some say, you don't have to take it, it's up to you, da-da-da. And so I said, if they gave you the option, just leave a comment of, what they said, and did you appreciate the option? But 54% actually said they just prescribed CL, or I say CL, so carbidopa, levodopa. Is that, like, what should be the practice to give people an option, or to get them started right on carbidopa, levodopa, so that you can learn and adjust from there? Like, what's best practice, I guess?
Yeah, it sort of comes down to, it's still realistically what are you dealing with every patient, so individual, and what's going on, right? The practice for many years prior to recently, which even today still holds true, is, we still don't have a diagnostic test for Parkinson's. Our only diagnostic test was, if we think you have Parkinson's, take levodopa. If you get better, you have Parkinson's. If you don't, you don't.
But don't we have that diagnostic test? It's a spinal fluid.
We have it's spinal. Yeah, but people don't want to go through spinal taps, getting insurance to cover it. It's not really realistic. Yeah. It's not still 100%. We have DAT scans. We have those sort of stuff. These are all still ancillary. It's still a clinical diagnosis. Yeah. And so, I when I'm still, okay, I see a Parkinsonism here. It may be PD, it may not be, it may be something else. And the option is, okay, I could put you through XYZ test to figure out what it is before I put you on med. Or put you on med. If you get better, great. Let's go. If you don't, then we could then do the diagnostic route and see something else going on. So it does come down to, in those ways, what is a patient's preference in terms of, hey, I'm somebody that I need to know before you're going to give me a pill. So I want to do every possible test that you could think of that's going to confirm my diagnosis, and then I'll get on board. Yeah. And then there are people that, hey, I'm tired of this tremor. I'm tired of being slow and stiff and I can't move. I don't know what's wrong with me. Make me better. Yeah. And then here you go. Yeah. This is what I have to make you better. And then there are, whether people are participating in research studies, exercise programs, right? So we have the SPARKS-3 trial, which you have to be levodopa naive to participate in. So then I offer that to patients to say, hey, you look pretty good. You may or may not need medication right now, but we have this trial. You can't be on medication to enroll in the trial. Yeah. So then that also can play a role into your decision of whether you're going to start levodopa or not.
Yeah, that's actually a good thing to think of, is if you're not on medication because you don't want to be yet, check out clinical trials because a lot of times they need people to not be medicated. Right. So do your duty. Anything else on carbidopa, levodopa, or like the medication that I might be missing?
I don't think so.
No.
And I would say in terms of, carbidopa, levodopa versus the other ones, I have like my personal, like what I go to, what I think is best practice for myself is generally speaking, if you're 65 and older and you're coming to me and I think you have Parkinson's, I'm going to go straight to carbidopa, levodopa. Just because the other medications, there's a potential for more side effect versus benefit. Now, if you're younger than that and you're having tremor's the biggest issue for you, potentially a dopamine agonist may do a little bit more for tremor control than levodopa does. Oh, okay. So then maybe consider trying a dopamine agonist in that scenario to get them to have, because tremor is really their biggest issue. Yeah. But they're younger and they're slow and stiff, and that's the bigger issue for them. I'm going to go straight to levodopa regardless of your age.
Okay, that makes sense. Because I've always wondered why Malone started me on ropinirole. But my issue was I had like restless leg. I had tons of stiffness in my leg, but I also had tremor. Yeah. But that was it. So now I have dystonia and, whatever else those words are. But bradykinesia?
Yes.
Because I leave my arm back here. My sister-in-law is like, I just want to push your arm back.
And all your glitches.
My glitches. So new word for dyskinesia, right?
Dyskinesia.
Glitching. Huh. My daughter was like, you like glitch a lot.
It's from that movie, isn't it?
What movie?
Inside Out. Is it called Inside Out? It's a Disney Pixar movie, and they glitch. Because it's in someone's brain, and they're like little, like sad as a little character,
and happy. Yeah.
And then when they're malfunctioning, was it that one, or there was Wreck-It Ralph also had a glitching. They glitch.
Let me guess
how
old you're. Yeah, I know. But no, that's funny. But yeah, so glitching is the new. And I actually, my mom, I was telling my mom about it too, and because I was just like laughing about it, because she said, she's like, how are you doing? You just still look like, not good. I'm like, no, I'm actually good. I get, very dyskinetic. And I was like, which, it's like Caitlin calls it now glitching. And she's like, can we actually call it that too? She's like, I don't like the word like dyskinetic. So,
and I would say, I mean, most patients would prefer to be dyskinetic versus the opposite.
Yeah, and I was telling somebody about that today, because I'm like, okay, going back to where I was, where I couldn't like really move my arm, and like every day I'm going like this. I'm like, yeah, I'd rather move or wiggle around a little bit. I
think dyskinesia tends to affect or bother families more than it affects the patient themselves, because they're like, oh my god, you're moving, like, are you okay, you okay? And they're like, I'm fine.
So that's why I'm very open with, even like with my friends, or if I'm sitting somewhere or doing something, and open with the kids too, because they're like, are you okay? I'm like, I'm fine. I'm like, it just makes me move. I'm like, but it's better than being in pain. So anyways,
great. Do we want to broach the topic, and yes or no, if you have any insight to people that try to medicate through, like, what's the word I'm looking for?
What?
Natural things?
Like shrooms and weed?
No, I'm talking about like
natural dopamine or other sources.
Yeah.
Oh, natural dopamine. Yeah. So wait, so I did actually, I looked into this before. So there's natural dopamine supplements.
Yeah, there's like Puna Kana or something like that, and then
Hakuna Matata.
It's Puna something.
Coming from Puna Kana.
So
my take on that, yes, and I have had a couple patients that do it. The problem with when you get these natural sources of dopamine is they're not regulated.
Right.
And so, although yes, it's dopamine, that we're not denying that. But the amount that you're taking, the amount that's actually getting absorbed, the amount that's getting in your brain, and dopamine levels fluctuate throughout the day in people who have Parkinson's and in people who don't have Parkinson's. And so it's this propensity of side effect is much larger, much more dyskinesia, because you don't know. You're going up and down. And then I don't know how to regulate that with the prescribed medications, which I'm prescribing. When you're doing this, we're kind of butting heads here, and then it's like my meds are, I don't know if it's my med that's doing it or it's the natural dopamine that's doing it. And so then I don't know at what point to give you dopamine, because we know we have to give dopamine 3, 4, 5 times a day, depending on what it is. But then when you're taking this external dopamine, then it's now we're kind of muddying lots of different waters. So that's with natural dopamine itself. But there's lots of still, other things like, thiamine B1 is a big thing. I have a patient who she is a prominent believer in it, and she's not on any levodopa, she's not on any anti-Parkinsonian medications. She has followed somebody who
Daphne.
is guarding her through figuring out thiamine dosing and things like that. And I saw her a couple of weeks ago, and she's still hesitant to be on any sort of medication, which is fine. But I evaluated her, and I've been seeing her now for 2 years, and I mean, her Parkinson's symptoms are exactly the same as it was 2 years ago. Is it the thiamine? Is it the fact that it's a slowly progressive disease? Is it her?
Or is it just because it's her? Because everybody gets it differently?
Exactly. Yeah. I don't know, but she feels so good. Her day-to-day, she feels like... So who am I to say, no, I don't want you to be taking thiamine. I need you to be on levodopa.
Yeah.
Well,
no. So for those who are still listening, the B1, we're actually going to try and get Daphne on here.
Oh, okay.
So she wrote a book about B1 thiamine. That's what it's called.
Yes. Yep. I have the book.
Yeah, I do. Yeah, I have it too. It was really interesting. But I actually would like to segue, but we'll make it a separate episode on the absorption of carbidopa-levodopa, or that whole like process. And I know we've talked about it before, like how it's absorbed and how much of it's absorbed and things like that. So we'll cut off now, and then we'll jump back into a different episode about the absorption with carbidopa-levodopa. So with that, 30 seconds, a minute, 5 seconds. I'll leave you with this. With carbidopa-levodopa, and you're talking to your doctor and you're skeptical, or they're having you try different things. In my personal opinion, I'm not a doctor, but just if you try and then you want to stop, and you're working with your doctor on it, there's really no problem with it. So if you want to help yourself as best you can to live as best a life as you possibly can now, try different things, but with your doctor's recommendation. So with that, we'll see you next time.